practice.
We're going to talk about the atopic dermatitis treatments other than steroids.
You've been watching Oppenheimer too many times.
Welcome to CFP Distilled November 2023.
I'm Dr. Paul Dillon.
I'm Dr. Simon Moore. In this video, we are going to go through all of the practice-relevant articles in this month's CFP journal.
So what are we going to go through? We're going to start off with some referred Otalgia, or
fantastic.
Are we going to do something right before that?
Yeah, why don't we start with breast density notification?
And then we'll move on to some myths about screening, and then straight into tools for practice. What's going to happen in tools for practice?
We're going to talk about the atopic dermatitis treatments other than steroids.
You've been watching Oppenheimer too many times. And finally, we're going to do Praxis Rapid Recommendation. So Danielle O'Toole's finest work.
Fantastic, and it's part 3. I know a lot of you have been waiting for those 2022 guidelines. We have them for you now at the end of 2023. And there is a great article on thoughtful prescribing for patients with difficult to treat depression, new nomenclature. But first, as we always do, where do we begin, Paul?
At the cover, and we have a beautiful cover, simple. It's November, so the poppy, great symbol from in Flanders Field.
You know, I told you there was going to be no curveballs like last month's podcast, but here's a curveball. I'm actually biased. I love this cover because I actually know Dr. Andrew Seal.
And who is Dr. Andrew Seal?
He is a plastic surgeon. Well, let me just put it this way. There are two kinds of people in this world. People who apply for awards and people who have awards named after them. And so he started Spring Gala at UBC Medicine. He is an incredible humanitarian, incredible plastic surgeon, incredible teacher. I'm starting to digress. So you get the picture. And
So stop digressing and start regressing into the table of contents and the cover.
Of
so what do you
beautiful
think?
poppies. Yeah,
so this is a surgeon who is doing an artistry course of some kind. And I think some people have said you can't be a good surgeon and a good artist. So,
well, if you look at his Instagram, he's got a whole beautiful panorama of his home studio. So
wow.
I guess that's what happens when you retire.
No, it's stunning, simple, but beautiful, with a great Canadian history with John McCrane in Flanders Fields, represented by the poppy. And
very significant meaning to that as well in November, as we always hold dear. Why don't we dive into the first article about breast density, and family doctors are getting notified about this. So what's next?
So this was interesting for me because often in my practice I would see BI-RADS 1, 2, and I repeat that back to the patients and verbatim almost read off what radiology recommended for next screening. But what does this article answer about patients who have increased breast density?
Exactly. So there's going to be a lot of questions that patients are going to have. They're going to say, why did the report say that I've got extremely dense breast tissue?
So it's because there are glandular issues. It's the actual density of the breast, but the clinical implications to that patient are the important part. And they separate it out in simple quartiles. So less than 25% fatty dense tissue is A. The small cancers are more easily seen. What's the problem with more dense breasts, over 75%?
It's going to be much harder to screen for those cancers. So there's some really practical tips in this article that I think we should be aware of when patients come and ask us about these.
So number one, you can talk to the patients about modifying the density of breast tissue. I don't know how valid this is going to be in real clinical life, but modifiable factors are smoking, postmenopausal, obesity, and a sedentary lifestyle.
There's even hormone exposure, if they're taking contraception,
sure,
or even diet may play a role. They didn't get into the granular of what you say to a patient for specific diet modifications, though.
So what am I going to be worried about in a patient who I've got some radiology back that shows they have more dense breasts? I'm going to be a little bit more worried if something changes. So that's not a great recommendation, but it's going to just peak. It's going to set off maybe not a red alarm bell, maybe a pink alarm bell.
So I think part of the message in this article too is patients need to be familiar with the density of their breasts, and if they are at higher density, maybe be a little bit more vigilant when it comes to them.
Yeah, so a great piece of information to give to your patients when you're using this shared decision making around doing any imaging.
Yeah, and if you're getting deep into this, if you've got a focused practice, you're seeing a lot of these patients, there is a specific tool, the IBIS tool, which was a new one to me.
I'm going to have to go back to that one. IBIS. Is that a European? Yeah. No, Egyptian.
Yeah, it's basically
the ibis stork.
Ibis? Oh, okay, yeah, you're trying to test my Greek mythology, which is quite weak. Like the throne of Dioclames. I just make stuff up and I don't know.
I can't remember it. I won't remember it. The slide at the review course.
Oh, yes.
In family medicine on breast cancer.
So that's one I do
screening.
know about
Which,
Artemis.
Who's that?
Oh my gosh, it actually comes together. Okay, so Artemis is the Greek god. You're just going to embarrass me afterwards and mock me for knowing this. But Artemis is the Greek god of fertility. And you may see this person depicted with multiple, like dozens and dozens of breasts. Thanks for letting me shine on that one. That's
Artemis.
amazing. Thank
You are my Artemis. Let's move on. To our next
I got one liner.
What else?
Iris tool predicts your risk of breast cancer. So it is basically like the Framingham of breast tissue.
Wow, it's a Framingham for everything. I'm sure there's more. There's more material, but let's keep going.
Okay,
keep going.
There is more material, so let's keep
first,
flipping
are we going
pages.
to talk about the adverts we see in here?
No, we can't talk about ads.
We can't talk about this drug that's going to show up in a future article.
Yeah, if we start talking about drug ads, it's going to keep us awake all night.
Ooh,
wink, wink. Insomnia
I have
drug.
insomnia.
Hey-oh.
Whoa, there's a whole load of 4 classes. Are there 4 classes? I think there's. What are the 4 classes of anti-insomnia?
Oh, we're actually going to do this. We're
Yeah,
reading
well,
through the
I'm not reading an ad. I'm reading educational information from
let's
an
just
ad.
tuck it in amongst the article so it looks educational.
Well, it looks very educational. More
interesting.
colorful than the rest of
Actually,
the
you know what?
journal.
If I was studying for the CCFP exam, this is a totally
It
fair
actually
question.
is. It's a really nice.
What are the 4 classes of insomnia medications?
So benzodiazepines, but you shouldn't be using them in the elderly. Choosing
that's what the
wisely
ad
and
says.
safely.
You
Yeah,
shouldn't use them because it's not an ad for
So what about the
benzodiazepines.
Z drugs
Yeah,
that put
those
you
are
to
your-
sleep?
those are
Is
your-
that why they're called Z drugs?
Well, because they all start with Z. Zopiclone,
Yeah.
Zolpidem, and S-Zopiclone.
S-Zopiclone,
They all
yeah.
have an S in them. All right, and then the
Z-
third class?
Doxepin, which is a non-selective monoamine reuptake inhibitor.
And then the final class is the orexin receptor antagonist. Interesting. You know, if I was studying for the exam, should we be focusing on new things to practice?
Sure, it's approved in Canada.
Yeah,
They
relevant
have a
to
bigger
family
marketing budget than all of the other insomnia drugs with their nice color.
Phenomenal.
Without naming a specific one.
No, not a single specific drug was named or listed as better than any other ones.
And for those people who wanted to go into internal medicine, on the facing page of the article, you can go into the mechanisms of action.
Because, patients always ask me about the drug's mechanism of action. But in all seriousness, though, some of these drugs do have a suspect safety profile that actually hasn't been convincingly proven, and so that's the downside of the medication.
Which one is that?
Well, it doesn't say in the ad. If you
shocking.
look at Tools for Practice, they've got a great article on that. It's in one of the updated slides for the review course for spring 2024, and they talk about the downsides of some of these drugs, which again doesn't make it to the drug company ads.
That was the 3rd page of the article. They couldn't afford it for the advert. So let's move on. Referred Otalgia.
Yeah, so basically this is like any Otalgia Paul sees because he refers it.
ENT.
Yeah, exactly.
Follow up with your family
Every
doctor.
Otalgia. So this article by a bunch of ENTs in Calgary is basically begging Paul, please stop referring all of your Otalgias. In fact, a lot of them aren't related to the ear.
Amazing. So what are the editor's key points? I think they wrote this one just for you. A complete examination of the head and neck should be
You're not going
performed.
to start massaging my face again like the last episode, are you? The submandibular massage? Okay, let's just skip that
So
part.
what are the parts? Palpation of the neck, examination of the oral cavity, oropharynx, anterior rhinoscopy. Are you doing that routinely, Simon, following the...
I actually do. So in all seriousness,
Yeah.
I'll take the otoscope and you put a ear speculum on it, and you don't tell the patient it's a speculum. Then it's a really awkward moment if you do. And then you basically flip the end of their nose up towards the sky, put the ear speculum up there, and you tell the patient, you warn them, don't take a breath when you're doing this, otherwise it's going to fog up my lens.
Oh, that's a great practice tip. Okay, interesting.
So the ENTs say we should be doing that, and we should, document that in your referral letters, show them that you've done everything.
It is easy. You can see kind of larger polyps in older patients who worry about cancer, for example. But let's get back to the article.
Well, that is the point, because the ear actually is the source of pain in less than half of Otalgia cases. So we should be looking for cancers is one of the main messages.
Interesting. I had not heard of that before.
So other places we're looking at dental problems.
Oh, come on.
Heard, okay. Clearly that one went right over my head and in
wait,
one ear and out the other.
How many kids do you have?
How many?
3?
I've got 3. Yeah,
How many
so
dad
it'll be
jokes can you fit inside a dad joke?
3,000. What? Oh, is there
I
one
don't
for
know.
that?
Dadception.
That's Nice.
Okay, let's get back to it. So referred otalgia. So you have to think, are there dental issues? That's not something I always run to, but yeah, definitely have a look. Sometimes patients just might have kind of a rotten tooth up there, some dental caries, and they're getting some referred pain.
My ear hurts. Head and neck malignancy. So again, pop SAM question, what are your risk factors for head and neck malignancy? What are red flags on history and exam? What they're going to talk about?
So dysphonia, it could have voice changes, maybe. We've seen these patients come in with their change in voice. Dysphagia, difficulty swallowing. This one for me is a worrisome thing. Progressive, and then bam, something made it a little bit worse potentially.
They don't come until it's stuck though.
Yeah.
They often don't. Odynophagia is really important to distinguish from dysphagia because it's not stuck swallowing, it's painful swallowing.
Yeah. Subtle but important difference, especially when you're talking to your ENT colleagues. And dyspnea, shortness of breath, a new neck mass.
I guess that's pretty obvious.
Yeah, it's pretty fairly obvious. It's like after Christmas time. Oh, what did you get for Christmas? A new
that's
neck
like
mass.
the McMaster answer to that question.
Is it?
Yeah.
How they answer questions?
Well, they only get 3
differently?
years of med school in McMaster, right? So, what is a risk factor for head tumor? If you can see a head tumor.
Interesting.
All right, great. Now that we've alienated 1/7 of our Ontario listeners.
3 years for med school and then a 3-year family medicine residency.
No, it's not 3
6
years.
years. What?
Due to the advocacy of someone else.
Did that happen in November?
Yeah.
Maybe that's going to happen in the future.
Speaking of digressing, did you hear about that one? Okay. So what else do we need to do? We look in the nose, we look in the throat, we ask about risk factors. You know what's really interesting though is because there's a lot of common innervation. The trigeminal nerve is going to serve for innervation of not just the ear, but also inside the mouth. That's why it all makes
Interesting.
sense.
I wouldn't have always thought that. Yep. Okay, fair enough. Oral mucosal lesions. And the interesting one I thought at the end, they finish off with it, but cervical spine pathology.
Yeah. You know, funny of you to just breeze over all of TMJ disorders, which, you know...
I work in the ER, Simon. This is coming straight back to you from me.
Yeah. See your family doctor for this, who's going to refer you to ENT, who's going to reject the referral. Because there's actually...
And you'll end up back
in the ER. Yeah, it's the cycle. The cycle of TMJ life, which is really unfortunate for these patients. It's really frustrating for them because it's hard to get a diagnosis and management. But, you know, I have seen a lot of these folks try and seek care and no one really gives them the first steps of treatment. So what would those be?
So mainstay of treatments is conservative therapy.
Yeah.
For the what's the type of joint? Giglio arthroidal joint.
Okay.
That's the TMJ joint.
Oh, wow.
It's the only one that slides and is an elbow in the whole body. Isn't that wild?
Okay.
Such a unique joint.
Wow.
Causes lots of
so
problems.
much Greek today. This is
Yeah.
amazing. Gonna need some. Gonna need to use a translation app to make it through the next CFP Distilled podcast. So we manage those folks with massage, warm compresses, and non-steroidal anti-inflammatory drugs.
That's what I would see in the ER for some of these patients. I would at least give them a trial of ketorolac to start with maybe, or some naproxen or ibuprofen at lowest possible doses for the shortest amount of time. Maybe PPI cover, but just see, especially if they haven't done it yet, can sometimes sort them out.
Yeah, and I think we can wrap this up with just a couple of last diagnoses. You mentioned cervical spine, you mentioned physiotherapy to those patients. And then what kinds of infections cause people to come in with ear pain?
So sinusitis would be the one that would be top of mind. And you can see this sometimes, and especially if it's unilateral.
Yeah.
Ear pain is bilateral, otalgia would be something different. But if it's unilateral and they've got a bit of a temperature, maybe low-grade fever, maybe a sniffly nose, think about sinusitis.
I think one of the most interesting ear pains I ever saw in residency was a lady who came in and she had burning and stinging pain, hypersensitivity to touch, and we diagnosed her with herpes zoster sign herpet, which now we're moving into Latin, which means without the herpetic lesions.
Yeah.
And sure enough, a couple days later, she came back with the rash I predicted she'd have. I felt so clever.
But then she had the rash, so your diagnosis is incorrect.
It was herpes zoster sign herpet.
Yeah, but you said she had it afterwards.
Well, that's the prodrome of it.
Oh, okay.
Are you on my side here, or what's going on?
Unilateral? Which side are you on?
Oh,
That's a zoster joke.
Hey!
But I think,
Okay.
yeah,
We need
interesting.
to stop reading each other's minds.
The other interesting ear pain I've heard about is insects in ears. So check
I've
for
seen this
insects.
too.
Have you? Did you drown it with lidocaine?
The bug was already dead. The patient said, "I feel like there's a bug in my ear," and I was like, "Yeah, sure." And there was a bug in his ear. I
love that when the patients are right.
Yeah.
You just have to believe your patients.
All right, now let's do this one in French. Otalgia referee.
Referee. That's someone getting in between, like
Yeah, I'll
battling
give you a
ears.
red card if we keep going on that one. So.
But hold on,
joke.
let's give some red cards to myths about screening.
That's good.
Let's do this one quickly.
Okay.
What are some myths about screening? And this
No, there's no
one,
myths
earlier
about screening.
detection results in better outcomes. No, screening saves lives.
But what about
No.
that 3
Did you just
Tesla,
say no?
4 Tesla, 2,000 Tesla MRI
New
machine?
technology, more benefits. It's got to be better. It's a new screening test. So
Gotta be
what's
better.
the reality? Page
gonna
700.
save lives, isn't it?
Save page 770. So we talked about, maybe no isn't the right word. Maybe there's some nuance here. So newer is better. Newer tests, everyone thinks they're going to be positive, may detect more disease, but you got to have some longer term studies in terms of screening.
More is better. Is that a myth as well?
Detecting more disease is not a synonym of benefit. So balances between benefits and harms, false positives, false negatives, those all have to be taken into consideration. What about screening saves lives? That sounds great to me.
Yeah, it saves lives, but there's also harm in screening as well. And then there's specific things that come into play with this as well. Disease-specific mortality, and people think that there's a perception of benefit from that. But at the end of the day, you need an absolute estimate of benefit as well as harm, and that needs to be transparent for the patients. My favorite anecdote about this is the patient who, just got a stress test to make sure their heart was okay, and it was a little bit ambiguous, so they got a cath just to make sure their heart was okay, and it was perfectly clear, but the patient had a stroke on the cath table. And so here you go. They just thought it was great to screen, but there can be realistic harms. We need to move into the mindsets of our patients.
Yeah. Brilliant. So let's move into the mindsets of our patients who may have atopic dermatitis.
Atopic dermatitis. This is going to be the pronunciation conundrum because we got our.
So what do we recommend to these patients? So
Steroids.
number one, no, short daily baths.
Lather
Now, I don't know.
piles of steroids in their face and folds.
No. Short daily baths, soap-free cleansers, and fragrance-free emollient twice daily. Now, what do you do if there's no bathtub?
Steroids.
It doesn't count for showers versus baths.
Oh, interesting.
I just had a
Okay.
patient who said they couldn't get their kids into the bath because they live in a home that doesn't have a bath.
Okay. Hot tub, is that mentioned in here?
No,
Number of jets. See, this research is flawed.
it's flawed.
I used
Shallow.
to think that Tools for Practice was high quality research, but they're not naming the number of jets per tub for
Nah.
actually helping these patients.
So it's tools for practice, good, quick, simple updates. What does this one say in the end about using some of these new calcineurin inhibitors versus steroids?
Yeah, so we all know steroids have got those downsides, and on your SAMPs you're going to be aware of, thinning of the skin, scarring, telangiectasia, permanent damage, and so your patient's going to say, but I've got it on my face, so what can I use instead?
What are the other options? So you could use tacrolimus is one, or pimecrolimus.
Pimecrolimus. and that's,
Pimecrolimus.
another
rolls
option.
off the tongue, doesn't it? So those are two options, and what this article ultimately is saying, they're basically equivalent. Tacrolimus might be better than
Pimecrolimus? Yeah.
But steroids are good enough. But that key consideration you mentioned about the SAMPs, what are some higher risk areas where you may consider a calcineurin inhibitor? And these are probably pretty cheap, aren't they?
Oh my gosh, yeah. So you're going to be paying 10 times the price for these fancy ones. Now, I remember there was
Tesla of creams. That could be like
Yeah.
a Tesla edition.
There you go.
Tacrolimus.
Costs 10 times
2.0.
as much. It goes about
There you
1/10
are.
the
10.
distance.
Yeah.
Amazing.
Like it. Nice.
So I remember there's a big hoorah hubbub about these drugs because people said, if you rub them on your skin, it can cause lymphoma.
Oh, I don't remember hearing.
So that black box warning was actually removed by Health Canada in 2021. They said, look, there might have been a little bit of signals on the research, but not enough to actually leave it on the label. But wrapping up, there's one huge side effect you've got to warn your patients because half of your patients using these calcineurin inhibitors are going to complain of this side effect.
To be burning skin.
Exactly.
My skin
Yeah.
is burning. I think it lessens with time, but something to obviously talk to your patients about, save them a return visit, set expectations.
Now, something that's been burning on my mind since 2022 was Danielle O'Toole's been sending out these rapid recommendations. I don't know if taking 2 years to get to print is that rapid, but after all, this is part 3 of the 2022 rapid recommendations. A couple guidelines to know, a couple that actually jumped out at us, really, really vital to know.
The SOGC updating its risk factors for pre-eclampsia and preventative therapy with ASA.
Yeah, so
That was a big takeaway, I think, in 2022.
oh my gosh, totally different than what I learned in my training. So we need to be prescribing ASA for patients who are high risk for preeclampsia.
And so who are these patients with risk factors? So two of the big ones include obesity and assisted reproductive therapy.
Yeah, take special note of those. Those are the new ones that came out in this guideline. So that's why it's so important.
And then what else is there? Risk factors for so what are some high risk ones?
You know, if they've had preeclampsia before.
Oh, easy. That's a quick mark on the stamp, but this big long list. What else? ART we mentioned, pre-gestational diabetes, chronic kidney disease, SLE, or antiphospholipid antibody syndrome. That's two answers on one line.
Yeah, well,
Can't do that on the exam.
That'd be wrong on a stamp. You've got to have one answer per line. For those of you who use memory tricks to remember these things, if you just think about the kidneys, you know that's going to be your hypertension, your kidney disease.
That's a great way to remember
your lupus. It's going to lump those three for you. So if you have any one of those, you should be taking ASA between 16 and 36 weeks.
Discontinuing. Yep. So boom, 16. So for 20 weeks of your pregnancy, you get an ASA. There was a couple.
Sorry, starting before 16 weeks and discontinuing by 36 weeks. And I think it's a good note to mention about the dose too.
So it's interesting. They talk about 162 milligrams. So two of them would maximize the efficacy, but the lower dose would maximize safety.
Yeah.
So if your patient is higher risk, I'd probably like to run this by an obstetrician. But if your patient's higher risk and you're comfortable, you're going to be giving 2 of the baby aspirins a day. 2 babies for the future baby.
Twin dosing and higher dose for higher risk. And then if you've got any 2 of the moderate risk factors, so your patient is pregnant, they've had an abruption, stillbirth, reduced fetal growth rate, there's a few more here. If they got any 2 of these, what else?
What else? Multifetal pregnancy or nulliparity, so first baby.
Or if they are over 40 years of age, those are the folks who were thinking 2 of those problems, then let's give you some ASA.
I think we should move on and get a couple of these others. Some of them are US-based. U.S. Preventive Services Task Force recommends screening children 8 to 18 for anxiety and 12 to 18 for depression.
Sorry, what? Teenagers get anxiety?
Yeah.
Wow,
and
that's
now we're
a great recommendation.
I don't know. I think this is a U.S. recommendation.
Amazing. They just noticed that in America.
Yeah.
Hey, okay.
And then if you don't have the resources to give these people, I don't know if there's actually going to be a benefit there.
Okay.
Next one. Ooh. Had you heard of this society before?
You've never heard of the World Federations of Societies of Biological Psychiatry?
Yeah, so it's not even just the World Federation Society of Biology, it's the Society of Societies.
Oh my gosh, that sounds high level.
Very high level. And they partnered with...
Did the Canadian Network for Mood and Anxiety Treatments join it? Oh my gosh, they did.
What do they call these things where like a restaurant to pop in? Collab.
A collab.
This is a collab.
Oh, it's like a beer that's brewed by 2 breweries.
Yes, exactly. Except it's 2 societies have got together.
Amazing.
Just make a new guideline.
And these recommendations basically look like the supplement section of my local pharmacy.
It looks like a great Indian recipe. I think you can make a good turkey. Right? St. John's wort, saffron, curcumin, lavender. That'll make it. Some specialized oils and zinc. Oh, and even ashwagandha. That is a depression curry.
That sounds delicious. That's amazing. Nothing brings me more joy than a good curry.
Good cooking, but so I don't know. This made it into the top recommendations. It's all weak recommendations for different adjuncts.
Okay.
They even I don't know if we should spend too much time on that, but this one.
Well, you know where this is actually really clinically relevant for me, though?
Is
because patients come to me, they say, well, I don't really want a medication for my depression.
Oh, interesting.
And then the second I say, well, let's talk about the supplements that have been proven to work in depression. Like seeing their whole tone and body language change. Like,
interesting.
This doctor's not like dismissing me outright.
But how do you sell a weak recommendation?
At a high price? Speaking of
I
drug
understand
ads.
where you're getting at. That's a great way to use this information to maybe, get the patient to make some other choices. Great point. What about this one? What are you going to have with your curcumin and saffron
so
in the evening? What are you going to have as your drink?
Another quote from the Department of Obvious Recommendation Guidelines. Less alcohol is invariably better.
That was not a fun guideline committee, to be honest.
I did not.
Imagine that. You're at the end of the hard day of building guidelines. You're like, oh man, hey, you want to go for a run?
Yeah. Oh. You're sipping a whiskey, reading your CFP distilled, and it says less alcohol is better. So this was an enormous splash in the media. And so we're talking, of course, about the Canadian Centre on Substance Use and Addiction, new Canadian recommendations on alcohol intake. And what were they?
So it's patients who consume 2 or fewer standard drinks of alcohol per week are likely to avoid alcohol-related consequences. Broad all-encompassing term. And the media, I think, spun this a little bit irresponsibly, like drinking irresponsibly. And I think it actually just makes that broader point. Everybody is different. Everybody's going to be unique. You're going to have different life circumstances, but overall, less is better. I think that's a fair enough message. I think if they distill it down to that, we'll actually see some patient-centered benefits from this.
Okay. They do have another couple of cutoffs and numbers to know about. So specifically, they say, if you drink 3 to 6 alcoholic drinks a week, then you are getting an increased risk of cancer.
That's fair.
And then more than 7 a week, that is your cutoff for increased risk of cardiovascular disease.
Okay. Now, if I'm sitting there as a patient, I'm getting that information. It's still a little bit too broad. I think if you just tell a patient you're going to get some sort of cancer, I don't know if that's going to change.
Yeah, I agree. I think saying
communication
less
is going to be
better.
Yeah.
Patients won't like it, but that's what the research says.
Yeah, but I'm seeing more and more patients who are coming in who are trying the alternate 0% drinks.
Yeah, it's amazing seeing the ads for that. I mean, maybe
local
Facebook just thinks
supermarket.
I've got a problem, but they say, there's lots of ads for alcohol-free cocktails. You see this in restaurants now. For those of you who don't have 3 kids and can make it out, but there's a lot more have alcohol-free cocktail menus.
Okay, we are almost at the end. I think this is the last article and maybe the most important one.
Yeah, I think this is the one about resistant depression.
What is it? Whoa!
That's
Is that
right.
what you
There's been
call it?
A nomenclature change.
Ooh.
So I really found this interesting as well. That the term now is not resistant depression. What are we calling it now?
Difficult to treat depression.
So that really
DTTD.
reflects changes in terminology in the field for various reasons. I just remember making slides for the review course. We got over 100 updates this year in our new course, and one of them is about the new naming for what used to be fatty liver disease. And a lot of that was initiated by patient advocacy groups. So now that's called metabolic associated steatotic liver disease.
So we're going to see more and more renaming over the next couple of years. So what about this specific one? So these are patients that are common to emergency rooms, family practices across the country. Patients who you've started them on an antidepressant, maybe you've given them 6 to 8 weeks, not working. What do you do? And you have to remember, a lot of the studies are only based on 6 to 9 weeks response rate. So that's what I find in common clinical practice, a time to reassess, is that dose working for patients?
So I really like how they talk about the 4 different medications that we can consider switching people to, adding on an adjunctive medication. So these are add-on medications for people who have already tried an antidepressant. Maybe they've already switched from the antidepressant. So what's your usual go-to? I mean, the drug companies really want you to start with antipsychotics.
Yeah, I don't think that's very common in family practice. If you're getting to this level with these patients, they're more than likely going to have seen, they'll be off the wait list, the 18-month wait list for psychiatry, and they'll have been seen once perhaps. Most common in practice, I would see mirtazapine and bupropion.
Okay.
Antipsychotics and lithium as adjuncts, I don't think that many family doctors are just going straight to that without at least trying to reach psychiatry.
So that's a really neat thing about this article, is it really gives you some guidance on not only should I switch medication or should I add medication, a great table on that, but they actually go into great detail about people with difficult to treat depression. What medication should we use? In what types of patients would we find this beneficial?
So I thought this was a great article because at this stage, you've been working with these patients probably for at least a year, if not 2 years, if not 3. Maybe you've known them for longer. And there are some benefits. These patients may have comorbidities.
So quetiapine can lead to weight gain. But
it's got better if dealing with comorbid anxiety or insomnia.
Yeah, so I would honestly, let's be honest, in real life, in clinical practice, I would not be memorizing this table. But I would look it up. I'd pull this really useful table 3 out and show it to patients and do a bit of that shared decision making. And it's worth it, as we wrap up. I do want to share an anecdote of a patient I saw just a few blocks from where we're recording in beautiful Vancouver. She was I tried her on I was doing a locum for a long term, 9th, 10th, 11th, and ultimately 12th antidepressant medication. And clearly I should have tried some augmentative therapy, which I think she'd done, didn't work. But I remember it was actually the 12th drug that it was worked. Like a light switch for her. Yeah.
Oh, wow.
Her husband came into the clinic and he brought me this enormous bottle of Yellowtail, like a magnum of Yellowtail wine. And he was just overjoyed. And I'll never forget what he said to me. He's like, Dr. Moore, I have my wife back.
Oh. That's lovely.
Yeah, it was amazing.
That's a lovely note to finish up this month's extended CFP Distilled. Some great highlights, great pearls, and we'll see you guys next month.
We'll take care, and we look forward to seeing you at CFP Distilled in December 2023. See ya.